welcome to the second session of the patient session in the ASCAT conference. We had an excellent program on the first session, and we hope that we will do the same today. Very excited to be able to present a distinguished panel of experts, expert doctors and psychologists and physicians, but more importantly, we also have a panel of expert patients later on who is here at hand to help answer questions from both healthcare professionals as well as questions from other patients. We have a very exciting lineup. On behalf of the steering committee, I welcome you all to this session. And remember that we are taking some notes from this session, and we will be highlighting some of the salient features in our plenary session later on in the week when as you know, this is a very closed meeting. Not everyone has access to this meeting, but some of the important learning points will be shared with the rest of the delegates later on in the week. So without further ado, welcome, and I will hand over to Dr. Colombatti to carry on with the introductions.
Thank you, Subarna, and welcome you all. So we have 5 expert speakers today who are going to address 5 topics that were chosen by patients through a European survey as the top 5 that wanted to be addressed. And the first speaker, because we start at the beginning of life, so it seems correct to start from newborn screening, is going to be Dr. Stephan Lobitz from Germany. Stephan is a pediatrician, a pediatric hematologist, and is also the leader of the German sickle cell newborn screening.
My topic is newborn and infant sickle cell disease screening, and the first question, of course, is why do we screen? Well, we screen to identify patients to make the diagnosis early and to avoid severe morbidity and mortality. That means significant complications or even death. This works because the early diagnosis of the condition enables us to counsel the parents about infection prophylaxis by penicillin or about vaccination. We can give information about signs and symptoms of anemia. We can teach parents how to palpate the spleen and so how to recognize splenic sequestration at home. But most screening techniques, there are different techniques, I will show it later, will also identify carriers. So that means persons who have only one healthy and one sick gene. And the identification of carriers may even help to avoid disease completely, because you can screening for patients means we identify patients, so they are already affected. Screening for carriers means we identify people before disease has occurred. This is a very wide field and includes many difficult ethical decisions, including separation of couples, abortion, pre-implantation genetic diagnosis, and so on. This is very, very complex. So when do we screen? In principle, we can screen at any time point throughout the whole life. Of course, the decision when to screen depends on what you are aiming at. Newborn screening primarily aims at making an early diagnosis, and secondarily to identify families at risk. And then there is what we call preconceptional screening, including a special form of preconceptional screening, which is premarital screening. Premarital screening means that you screen before, or you screen couples before they marry, and they are advised to separate. This sounds a little strange, but indeed it is done in some countries. For example, in Iran, so the parents are in some countries even not allowed to marry if both are carriers. In other preconceptional screening approaches, you can screen both partners in advance of a planned pregnancy to be aware of the risk for pregnancy and probably to initiate measures to avoid an affected child. And then there's post-conceptional but prenatal screening. That means that the wife is pregnant and you screen both parents, or sequentially first the mother and then, if she is positive, the father, to prepare them of having a sick child or to go for abortion. How to screen? Well, sickle cell or the sickle cell hemoglobin is different from the physiological hemoglobin, and there are various biochemical methods able to separate both hemoglobins from each other. And here's an example of a method called HPLC, high performance liquid chromatography. On the left hand, you can see a healthy person, in the middle a carrier, on the right you can see a patient. In this method, you will find peaks for the hemoglobins present, and in a healthy person, the hemoglobin A is predominant. In the patient, it's the sickle hemoglobin, and in carriers, you will find both hemoglobins. So how do we screen? We screen newborns at birth or during the first days of life. Most commonly, we use dried blood. That means you can see it on the picture, that you put it on a paper and it is dried and then eluted or re-eluted in the laboratory. Then you can analyze the hemolysate. So this is what you get out of this paper. And the typical pattern in newborns is the complete absence of hemoglobin A, the physiological hemoglobins. Then you will find an additional hemoglobin that you could not see in the slide before. It's the fetal hemoglobin that you only find in newborns. And you can also, and you will find hemoglobin S, the sickle cell hemoglobin. So the typical pattern is complete absence of A and presence of S, and this makes the diagnosis of sickle cell disease. This is a typical result. You can see the big peak is the fetal hemoglobin. This is physiological of the F, and then there's S, but there's no peak for hemoglobin A, and this is the diagnosis of sickle cell disease in newborns. However, newborn screening is not only making the diagnosis, but also reporting it to the parents and ensuring that test-positive babies receive appropriate follow-up. So the next step would be to confirm a positive test results and then to convey specialized care for sickle cell disease patients, ideally in a center for blood diseases. And it is also advisable to counsel the families, even the extended families, because if there is a sickle cell gene in the family, there may be other members of the family affected. So there is a risk of repetition for other family or future family members. So this was my presentation.
Thank you, Stephan. So I think we can move to the next speaker. We move from Germany to Italy, and she is Maddalena Casale. She was one of the pioneers of starting a sickle cell program in southern Italy, a region normally hit by thalassaemia. So welcome, Maddalena, and you're going to speak about neurological complications in sickle cell disease.
Hi, good evening, and Many thanks for the invitation to the whole organization, and I'll try to give you a brief overview on the neurological complication as I do in my hospital or with my patients, because your awareness is of great help to improve this complication. Why this issue matters? Because neurological complications are the most common and permanent complication in sickle cell disease, and without any primary prevention strategy, around 1 child in 10 will develop a stroke before the age of 18, as untreated children with abnormal TCD have a very high risk of developing a stroke every year. On the other hand, with an optimal implementation of a primary stroke prevention program, just 1 child in 100 patients will develop a stroke. And even more frequent are silent cerebral infarcts that are cerebral stroke without an obvious neurological symptoms that can be detected at the MRI. And they are very frequent because 1 child in 3 will develop a silent stroke and 1 adult in 2. So it is important to screen for silent stroke, not only for the high frequency we have already seen, but also because silent stroke predicts further neurological injuries, and they are associated with a drop in intelligence quotient and also reduction in executive function. Here I want to show you how the presence of an abnormality at MRI, like a silent stroke or an overt stroke, are associated to a progressive and more severe cognitive dysfunction in multiple domains. That means problem in speech, behavior, school performance or school attainments, employment status, and acts of daily life. That means also compliance with medications or medical appointments that can also impact on the management of the disease. I know this can be quite scary, but the important is that if we identify the main domain affected, we can implement a specific intervention at an individual therapy, like occupational therapy, physical therapy, speech therapy, developmental therapy to overcome the deficit. And now I hope it is clear that medical appointments are very important for the management of the neurological risk. You shouldn't miss any follow-up visit, any TCD screening when prescribed, and even if they are multiple repeated, because sometimes it can be necessary. And also, you shouldn't refuse MRI scan when prescribed, because they are important. It is important to detect subtle abnormalities. And furthermore, it's very important that you share any concern about your child's development, learning, school readiness, transition, behavior, mood, and also in adults, some difficulties in the daily life or at work can be a mild cognitive impairment. So pay attention not to label this issue as a problem behaviors or lack of motivation. They can be related to sickle cell disease, so share them with your doctor. And finally, it is really important to remember that there are some risk factors that cannot be modified, like having sickle cell, but neurological risk can be reduced also acting on modifiable factor, as in non-sickle cell individuals. So if you change your Lifestyle, improve physical activity, diet, avoid dyslipidemia, hypertension, obesity, quit smoking, and take care of other medical conditions, you really improve your neurological risk. Because all of us can do something, and so patients, parents, families, caregivers, friends can, working together, can do better. Thank you.
Thank you, Maddalena, for this clear presentation. We move, Subarna, I give the floor to you.
I now invite Jeremy Anderson to the floor. Jeremy is a colleague from London. He is a psychologist working at Imperial College London and has a great deal of experience looking after patients with sickle cell disease on the adult side. And Jeremy today is going to talk about adult patients' quality of life. So over to you, Jeremy.
Okay. Thank you very much, Subarna. Thank you for inviting me. So I've been asked to talk today about the notion of health-related quality of life in sickle cell disease. And what I wanted to say first is that really, although health-related quality of life has only recently become sort of measured formally, the notion of a quality of life has been reflected in medical practice really since its inception, right from Hippocrates. But this notion of practicing medicine in such a way that we don't cause harm, really, and of course we can put aside whether or not he ever actually said that, but really our codes of ethical practice in many disciplines related to medicine all understand that there is a balance to be found between the benefits of a treatment or an intervention and the potential harms. And our goal is to try to ensure that we're helping people more than we're hurting them. So what we're really talking about here is people's quality of life. So what is this idea of quality of life? What do we mean when we say someone has a good or a bad quality of life? Well, you can think about quality of life as being separated into two related features, but one refers to your subjective well-being, i.e. just how happy are you? How good do you feel about your life? And then the second one is how satisfied you are. That sounds like the same thing, but it's really about how contented you are. So your subjective well-being as an emotion can vary, whereas your general satisfaction with what's happening in your life can be different. When we talk about health-related quality of life, we're talking about the parts of your life that are a part of your quality of life, but they're related to your health or a health condition or the treatment of that condition. So having a chronic illness can affect your quality of life, largely because of symptoms or the other impacts on your life that I'll get into in a moment. But there's also to consider the impact of the various treatments for the condition that can affect your quality of life. And this can affect your quality of life in a negative or a positive way. For example, a treatment for sickle cell, such as hydroxycarbamide, it can affect your quality of life in a positive way if it prevents vaso-occlusive crises and keeps you out of hospital. But some people experience, various side effects that can also decrease their quality of life in other domains. And it's really the balance of those two things that impacts a person's quality of life. So when we think about all the factors that can influence quality of life, obviously there's having an illness like sickle cell disease that can affect you in various domains of functioning. And these can overlap. So obviously sickle cell affects your pain level, can affect how tired or fatigued you are. It can affect you emotionally. Other physical aspects related to quality of life, including your ability to care for yourself, your activity level, your stamina, your level of mobility or disability. But these things all overlap. I've spread them out for the purpose of the presentation, but all of these things overlap with each other. Having a chronic illness can affect your mental health, and also your perceptions, your beliefs, your memory, your emotional well-being, how sad or angry or satisfied you feel. It can affect your activities. What do you do for a job? What about your hobbies? How far do you go in school? How productive are you on a day-to-day basis? And something we don't talk nearly enough about is relationships. Our first speaker talked about neonatal screening for couples. This is one of the things that affects people's quality of life if they can have children, or if you're in a relationship but you find out that both of you are carriers or people have various illness. It affects the relationship and all of that. All of these factors taken together impact people's health-related quality of life. So how do we measure health-related quality of life? Right now, mostly we measure using questionnaires. There's a number of questionnaires that have been around for decades, including the PROMIS and the SF-36. These are fairly lengthy questionnaires broken into several different modules. SF-36 has 36 different questions. The CDC has a somewhat shorter health-related quality of life scale, and a scale that I use quite frequently is the EQ5D3L, and it's basically just 5 questions examining one's quality of life in 5 different domains, including mobility, self-care, your activity level, pain, as well as mental health or anxiety and depression. And for each question, there's 3 different options. So for mobility, you have an option of you have no problems with mobility, some problems, or you're completely immobile. And so you can have similar questions related to self-care and the other domains. So for self-care, it would be something like, I have no problems washing or dressing myself. I have some problems, or I'm unable to do those things. And so by the way that people respond to these questionnaires, we have a sense of what domains of their life that they're having a poor quality of life and what areas of their life are going well. So the various measures of health-related quality of life in sickle cell, the pain in sickle cell epidemiological study was the first one I came across that was a large-scale measure of health-related quality of life in sickle cell. And they found that in general on these measures, people with sickle cell disease have a health-related quality of life that's worse than the general population, and in comparison to other patient groups was most similar to patients undergoing hemodialysis. I think they were also very similar to patients with cystic fibrosis. I think with the exception that people with sickle cell obviously have more pain, but less mental health concerns. And so there's specific measures of health-related quality of life in sickle cell disease, including the ASCME and the JSAT. And so I'm not terribly familiar with these, but these are fairly detailed with various modules, including things like pain, stiffness, fatigue, and so on. So why is all of this important? Well, knowing what people's health-related quality of life is, it informs our treatment decisions. So again, a treatment might be very helpful in some ways, but if the side effects or the other consequences of the treatment outweigh the benefits, then maybe we would decide for a different treatment. just focusing on that, for example, maybe regular red cell exchange would reduce people's sickle percentage, but if it doesn't also, say, reduce the frequency of their vaso-occlusive crises, then maybe that's not a good treatment. Looking at what people's quality of life is like, we can estimate their likelihood of coming to hospital. And of course, if we know that a group of people with a particular illness that has an effect on their quality of life in different domains that we didn't know about, well, we can allocate new treatment resources to address those. And I think that's about it. So we'll leave questions for the end. Thank you.
Thank you very much, Jeremy. I'm sure there will be more questions at the end, but we will move swiftly on to our next speaker, who is Dr. Jean-Hugues Dalle from France, who is a bone marrow transplant specialist, and he's going to talk about survival, infertility, and other complications.
Hello, everybody. Thank you for your invitation. Just a few words regarding the stem cell transplantation and sequelae in sickle cell disease patient. If we look at the overall results expressing by the overall survival after stem cell transplantation from 1,000 patients transplanted in both Europe and North America during a very long period, as you can see here from 1986 to 2013, you may see that the overall survival was excellent, around 95% probably. We may have some differences regarding the stem cell sources we use for the transplantation, but if we use either bone marrow or cord blood from a sibling donor, brother or sister of the patient, as you can see, we have very, very good overall results. Two important things probably in order to consider the risk of sequelae and the risk of infertility is the fact that from the previous study I just mentioned, or this study published in 2019 by Barbara Capelli, you have to see this line that the wide majority of patients received a myeloablative conditioning regimen. Whatever the kind of myeloablative conditioning regimen, the important thing is to know that we use high-dose chemotherapy based on alkylating agents, and those high-dose of alkylating agents lead to either hypofertility or sterility, and we obtained the very good results I just present because we use such a conditioning regimen, at least currently, and it's very important to consider this point. The second point, very important, is up to now we use transplantation for the most severe sickle cell disease patients, meaning those patients with comorbidities associated to sickle cell disease. And as you can see here, the most majority of patients experienced before transplantation cerebral vasculopathy or stroke or acute chest syndrome or vaso-occlusive crisis or osteonecrosis, meaning we propose stem cell transplantation to patients with comorbidities, with a lot of pre-transplantation health concerns. If we consider transplantation at large, not just for sickle cell disease patients, I present here a cartoon from the LEA cohort. LEA cohort is a French cohort dedicated to the long-term follow-up of patients transplanted for acute leukemia, since acute leukemia still remained the most frequent reason for using stem cell transplantation in children. You may see in this cartoon that we described a lot of complications, long-term complications in patients who received transplantation during childhood. And if we may perform some parallelism between patient with acute leukemia and with stem cells is they are all transplanted during childhood, meaning they received a very aggressive conditioning regimen at time of a lot of body metabolism. Whatever the organism we consider, they are growing, and then the conditioning regimen may alter a lot of different organs. As you can see, we may describe cardiac injury, but as we know, some sickle cell disease patients present some cardiac injury during childhood due to anemia, due to stroke. They may present thyroiditis problem, growth problem, eyes problem, as well as bone metabolism problem. And we just saw in the previous cartoon that sickle cell disease patient may present it with osteonecrosis before transplantation, meaning that if we had some conditioning regimen with possible bone injury, we may increase some defect. We may have some trouble regarding iron metabolism and iron overload. We may have metabolic syndrome and other thing like that. Then we have to consider the health condition before transplantation, the impact of conditioning regimen and the intensity and conditioning regimen in order to identify the best time and the best patient with the best donor in order to provide the best result to the consider patient. If we look at the specific trouble regarding the fertility, we all know that when we asked family and patients some years after transplantation, whatever the disease the underlying disease indicating transplantation, the hypofertility or the sterility represents probably the most severe secondary late effect. But by chance, currently we may propose some, I'm not so sure it's a perfect solution, but we may propose some solution to patient, whatever you are male or female, and whatever the time we have to propose transplantation, we may propose some solution regarding fertility preservation. In male, if the patient is puber or in post-pubertal period, you may obtain a semen sample. I would say it's relatively simple, but in sickle cell disease patient, taken hydroxyurea before transplantation, you have to stop hydroxyurea some months before semen sample, and you have to switch probably hydroxyurea for transfusion program, and then you may have sperm cryopreservation and use sperm thereafter after transplantation. If the boy is prepubertal, you may propose testis biopsy and cryopreservation, but it still remains experimental at this time. It works in monkey, not yet in human species. Female, post-pubertal female, you may use ovarian stimulation for obtaining oocyte and then provide oocyte cryopreservation. In female with partner, you may propose in vitro fertilization and then embryo cryopreservation, but we may have some concern regarding hormonal ovarian stimulation in sickle cell disease patient because there are some trouble regarding the risk of thrombosis. And in prepubertal female, you may propose ovarian tissue biopsy for cryopreservation, and then it works at this time since several hundreds of babies are obtained after ovarian tissue reimplantation years after for bone marrow transplantation. Then we have some proposals in order to preserve fertility in sickle cell disease patients. Thank you for your attention.
Thank you very much for your talk. We'll swiftly move on to our final speaker. I'm delighted to have John Brewin speaking in our next session about the new therapies in sickle cell disease. John Brewin is a specialist sickle cell doctor who works at King's College Hospital in London.
Well, thank you very much for inviting me to talk to everyone today. It's a great privilege to be here today. So I've been asked to talk to you about the new and emerging therapies. And the first thing I want to say is that I've not got any vested interest in any of the medications that I'm going to talk about today. The first thing I want to say about the general landscape of sickle cell is how exciting it is in terms of the momentum that is coming through at the moment. This is some data I collected from the clinicaltrials.gov, which registers all phase 1, phase 2, phase 3, which are our medical trials being registered across the world. And this is a plot of them year on year over the last 20 to 30 years. And as you can see, there's a huge amount of new drug therapies being tested, which is very exciting. And these are all testing targeted against different aspects of sickle cell disease, different biological mechanisms, and hopefully as they start to emerge, we'll have a lot more to our armament to help combat the different complications of sickle cell. However, there are lots of drugs there, and I want to just focus on the 3 that have in the last few years been approved for use in the United States, although it should be noted they're not available currently in Europe or the UK. And I'll talk about some of the reasons why that might be as I work through these. So the first one that got approved in 2016 is L-glutamine. The trade name is Endari. This is an oral solution that you take twice a day. It's quite a lot, actually. It's 5 grams dissolved into water. Each sachet is 5 grams, and you have to take up to 3 if you're a regular-sized adult twice a day. The main effect of this is that it produces nitric oxide in the bloodstream and helps red cells stay nice and healthy, and this will help to reduce vaso-occlusive episodes. And it showed this in the phase 3 trial, the randomized trial that we had, although it was only a very modest reduction with patients moving from 4 vaso-occlusive episodes down to 3 episodes per year. So the target group for this would be people who are having painful episodes. The side effects are actually generally very minimal, although there were quite a lot of complaints about the taste of the medication, which can be an important issue in terms of whether you're going to take this medication or not, especially if there's only a modest reduction in the pain frequencies. And I think for this reason that it's not yet received approval in Europe and the UK because there's only a modest benefit to it. It can be taken alongside hydroxyurea, though the evidence supported that. The next drug that received this about a year ago was crizanlizumab, or Adakveo. This is a once-monthly intravenous infusion that you come to the hospital or have it administered at home in a day unit, perhaps. Again, this is targeting reductions of painful episodes and showed a slightly stronger effect than L-glutamine in the trial that the data is based on, where it reduced frequent painful episodes, frequent defined as patients between 2 and 5 painful episodes per year, but it was very effective against those who had very frequent painful episodes, which was defined as 5 to 10 episodes per year. Some of the side effects that patients experienced were some infusion reactions such as high fever or some nausea or joint pains, but generally, again, it was very well tolerated. The main drawback so far on this one is that it was based on a phase 2 study, which is an intermediate study. The phase 3 study, which is normally where drugs get their approval, is currently in process and has been recruiting for the last year. And there are trials to try and extend this down into children as well. This study did include patients with SC disease as well, and did show a beneficial effect on patients with SC. So there's a broader evidence base for this medication for use in all types of sickle cell disease. And the last drug that has more recently been approved, accelerated access, is Voxelotor, which is a once daily medication, although it's 3 tablets that you take at once. And the main effect of this medication currently is that it is very effective in increasing the hemoglobin level which would help to combat the anemia aspects of patients' sickle cell. So far, we haven't seen definitive data that this is going to have clinical benefit. However, there is hope that this will have effect against things like that are particularly dependent on anemia, like stroke and reduction in the velocity of transcranial Dopplers, which we heard about in one of the earlier cardiovascular talks. Some of the side effects that are associated with this medication is it can cause some headaches, some diarrhea, some abdominal pain, some nausea, and some fevers. And I think the reason this hasn't yet reached approval in the UK and in Europe is that because it's still awaiting further evidence of genuine clinical benefit apart from just raising the hemoglobin. But I think this is all coming through now, hopefully. Although these aren't widely available, I think they're very exciting and therefore worth mentioning is the curative therapies. We've heard already about allogeneic stem cell transplant, which is when the donor is from a sibling mainly. But this is gene therapy using your own bone marrow cells to genetically modify them and then give them back to you with a slightly less intensive chemotherapy regimen and avoid some of the complications that can be associated with receiving stem cells from another person. The results of this have been greatly improved by a drug that's become available in the last couple of years called Plurixifor, which helps to mobilize the stem cells from your own bone marrow so that we can collect them without having to use drugs that are very difficult to use, such as GCSF or using bone marrow harvesting techniques. So this has greatly improved the quality of the stem cells that we can collect from the patients with sickle cell to allow us to manipulate them better in the laboratory to produce a better quality product in the end. So there are 3 strategies that are being explored currently, all within the context of clinical trials. The one that is the most advanced is the addition of a normal hemoglobin gene using a viral vector. And earlier today, we were hearing in one of the physician sessions the efficacy of this, which is looking very, very promising in 25 patients who've received it so far. They've all had very good responses. Follow-up is up to 24 months so far. So there's not a great deal of long-term data yet, but it's promising so far. And that product is licensed for use in treatment of thalassaemia. So hopefully sickle cell is just coming behind that. Alternative techniques are to divert the bone marrow stem cells into producing a different type of hemoglobin, which is in your system, which is called the hemoglobin F, which doesn't contain the sickle cell mutation and therefore would be a very effective alternative strategy. And then the final strategy, which has always been the long-term aim, but never quite been achievable, is to modify your own DNA and change that sickle cell mutation back to the normal, regular DNA variant. This has proved difficult so far, but with the advent of far more sophisticated gene editing techniques, is now becoming a possibility. Unfortunately, none of these trials, as I said, none of these techniques are available outside of clinical trials yet, but they are promising. But we do need more long-term data to be assured that they will be worthwhile, and currently they're also extremely expensive. But in the future, I think these will be available. And then finally, I think it's important just to think about medicines that are becoming more increasingly available to the bulk of our patients in the world with sickle cell, which is in Africa. And there's been some excellent studies recently using hydroxycarbamide in this setting and showing that there is no increased risk of infections, importantly, no increased risk of malaria, and that dose escalation can be achieved to maximum tolerated dose, which is far more effective in terms of reducing painful episodes, acute chest syndrome, transfusion requirements and hospital admissions in the more recent study extension of the no harm trial, and there were no additional toxicities that were seen. Thank you.
Thank you very much, John. I will ask Esther, who is co-chairing this session, to ask a question from the audience. We have been sent quite a lot of questions for the experts. So if Esther could start off, and then Rafaela, and if we have time, shall we say one question per specialist? Because we had a lot of questions, but I don't think we can use all of them. So Esther, will I please ask you to ask the first question?
Thank you everyone for giving me the opportunity here today, and I will just go quickly to the first presentation on newborn and infant screening. So I'll ask this question now. I've heard about genetic modification to avoid children being born with chronic health conditions. Is this available for sickle cell disease? Is it a recommended treatment for non-sickle cell disease parents with diagnosed fetus or newborn?
Yes, in principle, it is available. I'm not sure what exactly the person means who asked this question, but there's, for example, pre-implantation genetic diagnosis that means you fertilize the egg outside of the body, analyze if the disease is inside the egg, and if it's not, you transfer it to the mother, and you will get a healthy baby. And of course, in the future, the technique John just talked about will probably be available to modify the fetus or the newborn at an early stage. In principle, it is available, but in my opinion, this is not the preferred treatment.
The next question is for the neurological complication. One of the questions that among the many is neurological complication life-threatening? Do the neurological complication pose a threat to the life of the patients?
Unfortunately, yes. The mortality for neurological complication is higher for hemorrhagic stroke respect to ischemic stroke, and is high in sickle cell, but is high in the general population because hemorrhagic stroke are a very acute and severe event. A recent study published in 2014 on the French population reported that for ischemic stroke a mortality of 4% and for hemorrhagic stroke of 30%, 10 times higher. But beside the type of ischemic stroke, it's very important the quickness to reach hospital when a patient develops a neurological event. So there is a sentence, the time is bright. You need to go to the hospital as soon as neurological event occur, because it has been reported that every minute during infarct, a cerebral infarct, every minute without no treatment determine the losses of a lot of millions of neurons. So as soon as neurological event occur, go to the hospital and start treatment.
Thank you, Maddalena.
So my next question is for John Brewin. I have lots of questions, but this one's probably the best one. That's kind of might be covering quite a lot of ground. So of all the new upcoming therapies for sickle cell disease, what are your preferences? Or is that applied only for certain medications that are applicable for certain patients?
I think that's a really, really good question. What are we most excited about? And I don't think there is one specific drug that I think probably the most exciting frontier will be the curative therapies if they can come through and show efficacy. But I think they're still going to be reserved for people who have significant complications. I think they're going to be prohibitively expensive when they first arrive. So I think the most interesting aspects are going to be the drug therapies that are coming through. I think crizanlizumab shows a lot of evidence or a lot of promise for reducing painful episodes. I have a lot of hope for voxelotor, although some skepticism at the same time as to whether it's going to be useful, because if it does do everything it promises to do, it will be very effective in helping to reduce stroke risk, which was, as we just heard, is a very important aspect of sickle cell health, and with that will also hopefully, I think, reduce cognitive complications as well. But I think it will always be a patient-by-patient assessment of what is the most promising for that individual patient's disease experience.
Okay, thank you very much.
Jeremy Anderson, this question is for you on quality of life. Do you really believe that sickle cell patients can have a better quality of life? And if yes, in what way and how?
Yes, well, absolutely. Yeah, I mean, the short answer is yes, absolutely. You can improve your quality of life. And the way you do that, it really depends on what area or what domain of your life you're suffering in. So maybe I can answer this with an example of a patient I saw some time ago. So this is a patient with sickle cell who was getting regular red cell exchanges every 6 weeks. And he'd been getting this for many years. And so that meant that he was getting injections every 6 weeks with a big fat needle, and he would need, and that was unpleasant. And you would think that over time he would get used to that, but he didn't. Over time, and I think it was partly kind of the procedure where the nurse would always say, you know, sharp scratch and don't look, and he would get a little bit upset about the needle, and over time his anxiety about the needle grew and grew and grew, so that he developed needle phobia. And so he was getting a treatment that was really effective. It was keeping him out of hospital. That was important. But the procedure was excruciating. And in between his appointments, he was really suffering because he was always filled with dread when his exchange was coming, even though it was working. He was so anxious, he was, you know, pulling his arm away. It was getting more and more difficult. And he was considering, when he came to see me, he was considering stopping his red cell exchange, which would have impacted his health greatly, but he was suffering so much with his anxiety. And so what I did was worked with him and on his anxiety, so that he could, I gave him skills that he could use to lessen his anxiety during his transfusions, and so now he's able to continue that. So it's better than just keeping him the same. His actual day-to-day experience is better now emotionally related to his illness.
Yeah. Thank you very much, Jeremy.
Many questions for the Jean-Hugues, but I think there are many adults among the audience, and the question was, can people over 40 years of age receive a transplant?
The question is not very, the answer is not very easy, but I would say probably not. We have some program developed currently with a reduced intensity conditioning regimen. Then probably we may use such a reduced intensity conditioning regimen in older patients. But when I said older, it's probably 25 to 35, maybe the higher limit is 40, but I don't think it's a good idea to propose transplantation to people older than 40 years for sickle cell disease.
Thank you greatly to the experts today. Your presentations were absolutely really helpful for us. We are now going to end this session and start our next session